how to lower, how to control estrogen on testosterone. This video is going to be such a basic understanding, breakdown of how androgens convert to estrogens, where in the body, what happens, what are the outcomes, where's the data, and how do you control it? Because just saying you have to lower your estrogen, certainly by means of a cookie cutter mechanism of using aromatase inhibitors, we know now, and this is 2025, June of 2025, we know that's wrong. The McDonald's medicine approach on that, guys, you know is wrong. I'm not saying that I'm completely against aromatase inhibitors. We're going to get into that down here in the technology. I'm just saying that it shouldn't be where you start, and it just shouldn't be you have to lower your look at that number from you're taking the vein, right? You're extracting labs from your vein, from your circulatory system. You're really not seeing in the CNS where it is. You can't. But if you go by feel and you understand the way it's done here, I promise you're going to really put this thing together. But you have to really start with the basis of where the science is. So let's go.
I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances in this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy.
Estrogen is definitely not toxic. It's needed. Everyone knows that from the brain, CNS, into the muscles, the bone, the heart. Prostate needs some, not too much, all over the body, right? So I'm going to break that down for you guys here, system per system. First off, so it's fascinating, isn't it fascinating? This mammalian physiologic paradigms that we have. Testosterone converts to estrogen. Isn't that crazy? The rib of Adam stuff. It's just fascinating. It's so spiritual to me, and it's just so, there's so much to sit. I could sit for hours and just try to think of where the origins are and how did it get here and what's the utility of it. And it's just so, it's incredible. It's just so harmonious in the world when you look across mammals and the utility for these hormones with men and women. So, I mean, who knew that men have estrogen? I mean, if you just fact check that, how many people on the streets that are smart people that have estrogen? I know young people and anyone who's educated is going to know that men have some estrogen, but they don't really understand the breakdown that I'm gonna present to you guys today. And I didn't know this. Over years, I've learned it though in the field of working with androgens. And this is this is from testosterone replacement guys, regular guys on testosterone, exogenous testosterone, all the way through a spectrum of men that are using androgens synergistically and combined, because it's very complex. So testosterone is a 19 carbon initially, and then it converts to an 18. You lose a carbon through aromatase enzyme. Very complex. It happens all over the body, and depending on where you are in the body, you have to understand the effects. Let's get right into that. So the CNS, right up top, we know that the CNS it's just a priority that it has to have, and actually creates and has in its own mechanisms for maintaining estrogens and converting and needing this metabolite, right, from androgen to estrogen. I read on this for about a few hours, and I just couldn't stop reading. I mean, the data now with ChatGPT and all this data, it's overwhelming. So I had to keep it simple. So the CNS primary source has its own and requires its primary source of estradiol. Now, again, there's 3 estrogens, guys. We're going to mainly focus on the most predominant type, which is estradiol. We call it E2. We know that it relates to mood. It relates to sex. It relates to trophic levels of maintaining your central nervous system, your cerebral cortex, not to mention the lower brain, for functioning, for life. It's just something that is inherent. to maintain your thrive, to thrive. It is just, and that's in part why testosterone is so beautiful, but there has to be control and balance, and it has to feel good. And you have to understand the Newtonian physics of everything together, equal and opposite reactions all over the body, especially when it comes to this biochemistry. So the source in the CNS has to have estrogen. It converts a lot of it. Most comes from testosterone, not all. There's other types of weaker androgens, and there's different estrogens, progestins. That's beyond the today. But this is like you're taking testosterone. It's converting systemically, everyone thinks, just to estrogen, but it's not true. It's happening in organ systems. You're not going to measure that here. I mean, you could do a spinal tap, or you could you could extract out of the brain, which would be insane, right? That would be like mammalian work and scientific work to give steroids and testosterone and to measure estrogen in the CNS. This is super, super complex now. And then to understand the different downstream effects on mood, on cognition, I mean, there's just no question. So I can't tell you guys, give us some feedback, give us some comments. That's the beauty of this channel. We stimulate here with me, and then we respond. We have comments from you guys, from people to really to see that, have you had a mood disorder on testosterone? Did it help? At a certain point, did it hurt? Were you moody? What did you do to control it? What are your doses? What drugs do you use? Do you use AIs? Do you use SERMs like Tamoxifen, Novadex, Relaxafine? Do you have gyno? All these things. I want it all to come out, guys. Try to be very succinct, and I apologize for only one language here, guys, in English. We're doing the best we can in the future to have translations into all the different languages in the world, because I just love all you guys. So again, CNS requires estrogen. When you're giving yourself testosterone exogenously, the injections, I don't care if it's testosterone decanate pill, which is getting bigger out there now. I do agree with that. And you have gels, and there's a pellet, right? There's nasal testosterone. Most of this is going to be just the injections. Could be sub-Q, could be intermuscular. We're going to go into that. Very important now. We're really going deep into a real specialty, testosteronology. It's a full day job now. It's a sub-specialty of internal medicine. Obviously, it's a little endocrinology, it's a little hematology, a little cardiology, right? Come on, guys. So when you look at this, we know that the brain is going to be first and foremost for your feeling, for your confidence, for your mood. It's your main sexual center, and you need some estrogen. And that's going to be, I'm telling you, after doing this for 20 years with thousands of men, one-on-one, it's every man's got a fingerprint. You know, men come into this world before testosterone with a subset of either no mood disorders or a little bit of mood disorders, guys, or depression, bipolar, standard depression, and then it's general anxiety and anxiety. And again, that's the basis for primary care doctor like me. That's the basis of mood. I have some general anxiety. I have had some episodes of massive depression in the past from situational things that have adjustment periods, and that I've gotten over with the grace of God. And that's why I'm so humble. And androgens, not to mention other drugs, are going to have an effect on your underlying mood. You have to understand, and just blocking estrogen is just not the way to go, but you may need to block some estrogen for you. You see, it's a dynamic. It's a moving target, guys. And I want you to understand that. Again, I could talk about the central nervous system forever, because that's the basis of, like, you're on testosterone and you feel great. Why is it? It's not just testosterone. It's the conversion to estrogen. Are you measuring it here? You can't measure it in here. You're not going to do a spinal tap. I'm just telling you, that's when the spinal tap is going to see what's in the CNS. Okay? Lumbar puncture. I mean, we're not doing that, guys. Okay? We're not doing, don't get any ideas. So, okay. So not toxic to the body, but if you have too much, you're not balanced. And you're not just going to use an aromatase inhibitor. Guys, if you're at a clinic that's doing that, you have to pop over and grab one of my testosteronologists. Look on the app, find a provider. We're growing every week. Really every month. We're adding more. I'm training everyone all over the world. You have to look at the provider list for testosteronology and see these incredible nurse practitioners, healthcare practitioners, and of course physicians. And they're a broad spectrum. You know, there's internal medicine, emergency room doctors, there's infectious disease doctors, of course endocrinology doctors, and psychiatry doctors. There's psychiatric nurse practitioners. I mean, primary care. It's amazing. But thank you so much, guys. Look into that. So next, where in the conversion in the body do we see the predominance in the importance of testosterone and estrogen conversion, muscle and bone? This is incredible. When you look at the bone, we know that women that have osteoporosis historically lose estrogen from their gonads, which are ovaries. We have 2 testicles, women have 2 ovaries. This is such a spiritual stuff, guys. It's so there's so much deep mammalian Darwinism on top of the Lord and really the universe and the powers. I'm really in touch with that. This part of my age, guys. It's just all coming together for me. It's so spiritual. So when you look at this, you really have to understand that men have testosterone estrogen, women have testosterone estrogen. There's a dynamic and you have to keep it balanced. And now we're in this world now, but there can be severe side effects. That's where I want you to understand. How do you do this? So looking at the bony matrix, we know there's estrogenic receptors. No question. Most men in this field, when I'm talking to you guys, especially if you're 30, 40, 50, 60 even, are you going to have osteoporosis? Well, you could if you're frail, if you've been on corticosteroids for medical purposes with drugs and alcohol, and just when you're older, 75-year-old men and older, you know, they have osteoporosis. If you fact check this is phenomenal. This is one of the reasons why we should really understand to use, this is for you guys, for your fathers, you know, and not to mention mothers, we have to be careful. But to the interplay of the androgens and estrogens on anabolism, you see, because estrogen is anabolic to the bony matrix. You see that? Now, so we know that in bones. We know that in bones. So when you look at muscles, I had to do a deep dive. I wasn't sure. I had to look at that. Here's what I found, guys. So in the muscle tissue, you have the new technology. We have a lot of science on this now. We have estrogen receptor alpha, estrogen receptor beta, a G protein coupled, and there's even gene transcription estrogen receptors. This is just phenomenal science. So when you look at muscle, I thought, you look at powerlifters, you look at, again, whole bodybuilders to the side. That's the cosmetic guys. Love you guys, but it's cosmetic-y, and they have to cut estrogen for the cosmetic look because you can't hold water, right? And we know that they stop testosterone classically, and they go to dry drugs in the end, and a lot of them don't feel good. That's phenomenal, but that's a cosmetic thing. Let's look at powerlifters and strongmen. Their heads are like balloons. Right? Come on, guys. They're big and strong. When you look at the estrogen on paper, it's typically off the chart because they're on test, Anastrozole, Dianabol. Don't argue it. I mean, it is what it is. Now, when you talk to them, they could actually feel great. But of course, when you're on all those drugs and you're competing and there's stress and you're massive, there are points where they are up and down. But when you look at the effect, let's just, again, that's the CNS. Look at the effect of the muscle. Unbelievably protective. Look at powerlifters. Look at the Olympic powerlifters, Olympic lifters, right? The old Russians, right? Now, of course, the guys are lean now in the lower weight groups, but look at the heavy. Look at the guy that has the belly, and he's clearly overweight. He has adipose tissue. That's that's the mass, right? There is physics on it, but we know that his joints and his muscle apparatus, tendons, are completely protected. Do you think powerlifters take anti-estrogens? Hey man, before I go to the world's strongest man, let me pop some Arimidex. No way. No way. I've been doing this 20 years for some of those guys. Thank you guys for trusting me. I have to protect the heart. That's my heart work. So when you look at this, we know that. But of course, they're big and puffy. Faces look like a balloon. They're puffy. They're not cosmetic. But as far as the joints and their muscles, come on. That's all the estrogen inside the muscle. These receptors synergistically with androgen. So you can't argue that. And again, is it balanced for you? CNS, muscles, bones? Let's keep going. Let's get down to the gyno. Gynecomastia is going to be such a classic piece, right? So the brain, how you feel, the moodiness is a classic piece. You have to balance your estrogen, control your estrogen. You have to do it manually with the androgens and try to microdose. We're going to get into that the best you can without just using the blockers, because it's just not sustainable. And I'm always going to give that underlying theme. I don't hate the drugs. I'm not against the drugs, guys. I'm against the improper physiology and regimens that are not proven. That's the real truth. So gynecomastia, we know that you're converting systemically from testosterone to estrogen. It is circulating and it's stimulating very sensitive glands, mammillary glands, and there's two types of gyno. There's sensational, where you feel it's burning, right guys? And then you have, of course, the mass itself. Now, when I talk about gynecomastia, I want to say gynecomastia versus body habitus. The gyno is really directly on the nipple, or it pushes it out, and you can see that classic gynecomastia image if you just Google it on bodybuilders, and it's a little tit, right? It's a little bitch tit. It's a little tit that comes out. Depending on your genetics, how your structure of your muscle is, I don't really ever have had it. And I've been on up to 750 milligrams of test back in the day. You see, it's just genetic. You know, and because my nipples are kind of facing under, not up, like so, in the shirt, you just don't see it because my nipples are under the pec. You see, they're flipped under. My nipples are under. So the peak part right here sticks up. Some of you guys, it's just all genetic. It's just how you're designed. It's not right or wrong. It's not better or worse. Some guys will have the nipple coming out in the shirt. It's just luck. And again, I've seen guys on up to over a gram of test, and I've looked at the estrogen, and it's normal. It's unreal. That's unusual, but it's just fingerprints. So gynecomastia is a big piece because again, the stimulation and the sensitivity of the carryover in that mammalian tissue is just really important. And I know the brain in the gyno is the most important piece really for where men think they should lower their estrogen on testosterone. I understand that, but I just know that do you have really just fat tissue, and is it not gyno? You should go to a great doctor. And I'm not pushing plastic surgery. I'm saying if you're overweight, you should lose as much weight as you can, but there's still, from a cosmetic standpoint, guys, I've worked with tons of regular people in the world, not just these fitness people that are kind of over the top and obsessive compulsive, and we all have bigorexia. We're all obsessive compulsive, right, to some degree. It's good, and it can be very, very bad. But when you look at real people that have been overweight and they want to lose weight, you're going to have residual fat. You're going to have residual skin and adipose. You need to work with other caregivers to lose as much as you can, stay stable and healthy. And then if you don't like your cosmetic feel, just to live on aromatase inhibitors to eradicate what's not even gynecomastia is wrong. That's my driven piece home here to you guys. If you're a trainer, if you're a doctor, if you're a coach, if you're a friend, if you think you're just gonna control your gyno from the get-go, that may not actually be gyno. It's body habitus, which just means you have fat in that region, and it's not gyno, but the gyno's on top of it. I'm telling you, you need to go to an expert plastic surgeon to get an evaluation. I want to help you guys. Okay, I'm not pushing crazy plastic surgery. I'm saying get an evaluation, and when they remove those glands, It is unbelievable for so many of you. The problem is solved if you have a great surgeon. So again, you could use raloxifene transiently. You could use tamoxifen transiently for sensational gynecomastia. You have to affect and lower the testosterone by microdosing. We're going to get more into that here as we go into the technology and the real manipulation strategies. But when it comes to, is it gyno or not gyno? What is it? You have to understand the physiology that there is going to be a pipe up of that tissue depending on your genes, how much testosterone, are you overweight? And there's an interplay, definitely, even foods and drugs, come on guys. But in the end, if you're not happy with it, I don't want you just living on and overdosing on aromatase inhibitors to prevent or to reduce gyno that you may even have. It's not going to work. It's not sustainable, and it's going to end very poorly with side effects of the central nervous system, with depression and flatness, erectile dysfunction, even massive depression, worsening anxiety where it should help anxiety with the estrogen, but it's not going to be sustainable. Tendon issues, heart issues, cholesterol, bony issues. So you want to come to the app. Let me help you with my testosteronologist to understand just your fingerprint and how this whole thing should be done. Let's keep moving. Fat. The fat, the visceral fat, we know converts. Well, let's go. So we're out of the brain, we're out of the muscles and bones, we're out of the gyno itself and the mammillary gland. Let's go into the fat all over your body. Men that have more fat are going to convert more to estrogen because we have this aromatase enzyme in the fat. I know a lot of you guys know it, but for all you men that don't know it, isn't that fascinating? So if you, men that are very, very lean, I'm talking less than 10% body fat. And again, I'm not pushing for that, guys. I don't want to push potentially. This is harm reduction. I'm a harm reduction guy. I don't care the cosmetic stuff. I care about health and happiness and sustainability. So I want you to understand you should be happy. But if you want to get down leaner and leaner and leaner, you don't, it's great to go like this, right, guys? But I got a little belly, right? I try to keep a belly down though, guys. But my vital signs are perfect because I take my ABCD medicines, my supplements and my approach and my behavior. So because I don't want to have a heart attack. And I'm 60. And your mental health is everything. And sustainability and estrogen, right? So the balance. But if you're lean, lean, you're going to convert less estrogen. It's a motivation. Hey man, doc, what else can I do? I can't take those AIs, but I don't like that estrogen number, and I don't like the puffiness and the bitch tits a little and my brain up and down. I cry when I see a movie. I kind of like that I'm emotional. My wife likes it, but it's like, I don't like it. You see? Guys, I know what's going on. So you have to balance it with your dosing. And maybe you could really get in great shape. I've seen guys really get in great shape, motivated, and it helps their heart, it helps their back and their bones. The red blood cells go down because the hypoxic drive goes down, right, to some degree, and they just feel better and they're in much better shape, and it's healthier for their heart systems. And then also they convert less estrogen. Okay, so that's important. So visceral fat. Next, edema. Edema. Look at the man here. Guys, look at that picture. Come on, I'm definitely not an artist. Look, so we have the brain, we have the gynecomastia, bitch tits, we have the muscle and the bone. We talked about fat. Edema, that's the ankle swelling, or your face is swollen. You're on testosterone, you're puffy, my estrogen's up. Yeah, sure. There's no question about it, guys. So in the blood vessels, it has estrogen. Again, I did a deep dive on this stuff real too. So it has receptors, and you get this increased permeability where your body's going to lose in third space fluid, and that's edema, pitting edema. Guys, it's fascinating, and it is because of estrogen. There's no question, and it is something where, and androgens to some degree, and hypertension. This is a rabbit hole, guys. That's why my ABCDs is the basis of living really, as long as you can, free of disease. And then when you put it on testosterone, it's mandatory that you have to know A, B, C, D, S. And the only place to get that is inside the Testosteronology app. Come aboard. So edema, blood vessels increase their receptors for estrogen receptors in the vasculature. Okay, let's move on. Gonads. Gonad, another system. Before you're on testosterone, when you're in puberty, even in utero, I did a deep dive on this stuff over the years. There is, obviously your testicles have serotonin Leydig cells. It's producing semen, sperm, and testosterone inside the testicle that delivers outside. It's just to the testosterone comes from the testicle. There's a hypothalamus pituitary gonadal axis. There's a feedback loop, and estrogen is crucial. Now, and there's receptors for this, for estrogenic receptors in the hypothalamus, in the testicles itself, in the pelvis region. Now, this is urology. Once you're on testosterone, guys, that whole system kind of goes to sleep. Go to sleep. And if you're using HCG, which I'm all for it, but it's funny that, isn't it interesting that if you're using HCG and you're getting synergy of exogenous testosterone with your endogenous testosterone from LH analog or even FSH analogs in Brevell and Ovidril and all these, and clomiphene and clomiphene. Okay, you're using, that's all out there now, guys, to maintain fertility for men that are on testosterone. It's possible, but it is complicated, and the estrogen goes up. Isn't it interesting that the anti-estrogen class of SERMs, clomiphene and clomiphene, even tamoxifen and meloxifene, isn't it interesting that they're anti-estrogenic? Well, they're really modulators. Some parts of the body, they stimulate receptors of estrogen, and other parts they block. Okay, so, but isn't it interesting that, for an example, clomiphene by itself or even with testosterone increases estrogen? You could fact check that, and you could just, anyone who's on, they know it. It's like, wait a minute, I thought it's an anti-estrogen. It's not an aromatase inhibitor. That's a systemic blocker where you're blocking the testosterone 19 into the 18. Guys, this is well understood. This is well understood. This is like testosterone ology 101 here. So when you're looking at the testicles itself and you're on steroids and testosterone, I'm not saying they're not important. I'm just saying that we're going to keep it to the side if you're looking at pulse cycle therapy, or if you're looking at to maintain your testicles because they're shrinking and you don't like that. But I'm going to be honest with you guys. After time, I've been on for 35 plus years of this steroid and testosterone, right? 24/7, certainly for over 30 years. Had to come off to have a kid or two right here and there, my 2 kids. But the truth is, guys, at a certain point, your testicles are going to be atrophied, but the sex is phenomenal as long as the balance in the brain is good. That's the sexual center. Hypersexual, actually. Be careful. And as long as you have good blood flow to the corpus cavernosum, the nitric oxide, and that is my heart, that is my A, B, C, D. You're going to have a great effect because you're stimulating your brain and you have a response and everything's connected. And you're bypassing your own androgen system with exogenous androgen. And for most men, for years and decades, look at me, I'm 61 this year, that you feel just phenomenal if your ABCDs are tight, because your vasculature with nitric oxide, I've developed the protocols, guys. The cock is like it's freakish. But again, it's ABC, and A1C's got to be perfect, blood pressure is perfect, and the cholesterol and the coronary artery and the endothelial. Guys, this is the now and the future. You have to understand it. But when you look at this in the testicles, you're going to be shut down. You're going to have to be on testosterone forever. You're going to have to be in this rabbit hole understanding all this. That's for you young guys or guys that are middle-aged or even older that are considering testosterone. It's a lot of work, guys. But if you're ready to do it, I'm always here to help you guys to understand the science here and the clinical experience in the streets. I've been over 20 years doing this now. Okay. Prostate. We're going to close up on the last system. You can't forget the prostate system. When you look at prostate, BPH, benign prostatic hyperplasia, the enlarged prostate of a man who's getting older, it just happens. Estrogen's playing a role. We see you could fact check this. Talk to urologists. That the ratio of testosterone, androgen goes down, estrogen goes up, and this is the plight. This is the underlying etiology in the prostate, no question. And even potentially when we see the BPH enlargement, no question. There's other things going on too, guys. There's a lot, but we know this as a man gets older because those ratios change. This is a natural man. We're not talking about testosterone. Now, we know that with prostate malignancy, there is also a role. And I'm going to just stay very quiet on that because I'm not a urologist and I've seen the data, but I want to tell you this. There's no data that says testosterone exogenously will cause a prostate malignancy with a man who de novo has no prostate malignancy. And a matter of fact, this is Abraham Morgenthaler's data. You could look up him, Abraham Morgenthaler. He's a doctor, a urologist. He's been out here longer than me. He's in this androgen space. He's a urologist, though. He's not internal medicine like me with the heart and the blood pressure and all that, but he's a surgical urologist, and he's absolutely an expert in testosterone. He has shown us with legitimate data that all the urology doctors agree with now that testosterone does not cause prostate cancer. And there's something called testosterone saturation model in the prostate. You can Google that, you could look chat GPT it, and you could read for days. I mean, so now again, you are a man and you have a prostate, you better understand the PSA and the prostate clearance and BPH versus malignancy. You better. These are my ABCDs. Yes, the S is screening. Yes, the S is PSA because that's all we have. And we also have urologists, digital rectal exams, and we have MRIs, right, of the prostate. But I deliver this to I always tell you guys, around the age of 40 or so, you're going to be very smart to have whatever doctors you have, a testosteronologist. You have to have a testosteronologist, and you're going to be mandatory around the age of 40 to 50 to have a urologist who owns and manages your prostate. That's how all my patients do it with me. I mandate that, and of course I do it myself with my own urologist. Very serious. They're a surgical urologist. They own the prostate. Please listen to me on that. Let's keep going. That's the end of the systems. We have the CNS, we have the gyno, the muscle and bones, we have the gonads, we have the fat system, we have the blood vessel system, and the edema, and of course the prostate. Let's go into this now, guys. Testosterone dose. How do you control your estrogen? Now we understand the systems. So it's microdosing. It's effective doses, guys, the lowest effective dose. There's different types of testosterone. There's topical, there's pellets, there's oral, which is playing more of a role these days. But it's a pain. You got to take it twice a day with fatty food. I mean, it's a limit right there. But it can be, it's a game, it's coming into the game. It's going to be a game changer for some guys. Certainly guys who it's expensive mostly. And if you get right now in America, there's still trade name. I'm not going to talk about the trade names. You can see what they are. And beyond the fact of taking it twice a day for compliance, it's expensive, and it may or may not make you feel as good as injections. The old school injections are never going to be dethroned. Never, never, never. I did a video why testosterone injections are king. You could see that video. Mark, put that video up here in the corner for guys to see. All right, so intramuscular sub-Q, cypionate, enanthate, propionate, testosterone undecanate, you have oral versus long-acting injection undecanate, and Sustanon 250. You just have to, again, the testosterone undecanate, the oral, very short-acting, the injection, the longest-acting. How amazing is that? That's a real spectrum of the bipole there. So, but take undecanate and put it over here, okay? So we're going to be taking cypionate, enanthate, and Sustanon 250. You guys, that's, if I'm gambling right now, that's what you're on. That's what you have available. And it's IM versus sub-Q. Now, The difference between that for estrogen control certainly is this. The intermuscular compartment has more blood supply versus the subcutaneous compartment, which is into fat. When you're injecting these esters into fat versus muscle, because the fat has less blood supply, it's gonna leach into the circulation potentially slower and more regularly. But it can also cause hematoma, bleeding and bruising, and if you have to inject tiny doses, and it's typically in the sub-Q belly, or it's going to be anywhere you could pick up the skin in the leg and do sub-Q. There's no rocket science, guys, but I still in the end don't see a massive difference on that. Time will tell. But if a guys like to use the sub-Q, I let them do it. You just have to use small. You can't put a big milliliter into your belly. If you do, good for you, but you small baby do, and let us know what you do. Guys, if you're doing this sub-Q versus IM, it could be a game changer to really control the estrogen on testosterone. The sub-Q, if your doctor's having you go in a big dose of testosterone every 2 weeks or a month, I respect that doctor, but I don't respect that. You are not doing that anymore. If you're at a doctor's office and they're giving you a hit every month or every 2 weeks, that is wrong, because your dose is going way up and way down. Estrogen controls all over the place. If you probably don't feel good, those are guys that come to me and they go, "Doc, my number is lower than it started." But of course, because he's checking it 2 weeks or 3 weeks after the injection, of course it's going to get way up and way down. This is really, it's an embarrassment for doctors that do that. That's just an embarrassment. If you're taking esters of testosterone, the common esters, cypionate, enanthate, Succinone 250, you have to microdose them. But you don't have to microdose every day. I can't do that. I like the small dose for cypionate. The concentration that we have mainly in America is 200 per milliliter. I take 0.5, 100 milligrams, intermuscularly injected every 5 days. And I look at the nadir. I don't look at estrogen. I don't care what estrogen is. I haven't looked at estrogen in years. I actually do look at it for you guys to make videos, and it's usually high. But do I care? I feel great, but I want to protect my body parts. So I'm a data guy. Okay, so let's keep going. So this is testosterone dose. You need to microdose to control. I say it over and over. Next, what else is going to affect the control of estrogen on testosterone? Your weight, your genetics. For aromatase, there are men that have, when they get to a certain point in age, even young men, very rare though, with some gene deficiencies of aromatase enzyme, they don't aromatize. And that is in part with normal testosterone, low normal, or hypogonadism, frank hypogonadism. Guys, I've seen it. And then when you give them the testosterone exogenously, the injections, they start to aromatize because you're giving them more substrate. And they feel wonderful because you're bringing them from low estrogen low estrogen to normal. And then, of course, as far as the regimen from injection to injection, you have to understand when you're looking at that, is it peaking? Is it trough? Is it up, down? Are you on the way up, on the way down? What other drugs have you taken? Your body fat, the other medicines. If you have liver or kidney disease, there's going to be effects. Guys, this is multifactorial. Okay, so I want to really hammer that the dose. You got to microdose. I did the sub-Q and IM, enanthate versus cypionate, oral. I did that. Weight. So again, if you lose weight, your diet, alcohol really does affect aromatization. It increases it. Now, what else can I say that for this? Supplements that are great supplements that can be used as weak anti-estrogens to maybe balance. So zinc, DIM, old school, calcium, glucarate. Now, I did research on this one. Calcium glucarate, it enhances the body's ability to remove toxins and excess hormones like estrogen. Fascinating. So I'll be probably putting something together like this. Soy, we know that soy is estrogenic, so that's something you have to understand. And then, of course, the leaner you are, the healthier you are versus overweight. And I have this MASH, right? This is NASH. This is the fatty liver disease. So when I did the video, I could piggyback to get your attention on estrogen conversion and control on testosterone, how you really should be looked at. I'm going into the weight stuff, and I know that so many people in the world have fatty liver disease, and you can Google that. Now it's not called NASH anymore or fatty non-alcoholic fatty liver disease. They've changed the terminology to MASH. And I want you guys to really, if you really want to take great care of yourself, you got to come to the app. You got to engage yourself in this this study, which is a subdiscipline, testosteronology of internal medicine. Because now I'm into hepatology here and the GI stuff. So this is metabolic dysfunction associated steatohepatitis from just being overweight, and the liver gets fatty liver. Guys, when the liver gets damaged, say from alcoholism or from poor functioning liver function, estrogen goes up. So alcoholics that have cirrhosis, where they get gynecomastia, it's because the body has problems and it loses its ability to control estrogen. Estrogen levels go up. Fascinating. Fascinating. So again, this is the reason don't drink too much. I love my little bourbons, keeping them to a down low with the grace of God. And you should not smoke ever, guys. And if you do, please quit. Please do the best you can to quit. To cut them down significantly, please. It's going to be helpful for your overall sustainability and your quality of life. Please, let me help you with that. So next, medications. So we talked about the control. We talked about the microdosing, and understanding the organic testosterone dose is key. Not to take too much. To understand the types, you could certainly, I'm going back up for a second, a little addendum. So cypionate and enanthate, propionate, succinon 250. There are differences with that ester, with the hydrocarbon ring. There are half-life difference, peak of concentration differences, and I know that there are also differences when you look at the carrying oil, MCT oil, cottonseed, linseed, and grapeseed. I know it, guys, but do you need to really hammer down and drill down into this stuff? I think some men do. And it's not just estrogen, it's just so many pieces to them because they're very sensitive. It's called chemical sensitivity. I'm an internal medicine doctor. I was a primary care doctor for men and women. Some people are chemically sensitive. You know, they come in a room and the rug can be toxic to them. It's not bullshit, guys. So most of us, I think, that are in the steroid world are pretty averse to chemical sensitivity because we could tolerate it. One of the requirements to be a good steroid user is you got to tolerate tons of drugs and just feel great. How many guys take some steroids and they just crash and burn, and that's great to one degree because they'll never do it again. Right? They don't feel good. It's like the guy that drinks and gets red in the face and terrible drinking, or smokes a cigarette and just coughs his brain. Can't stand it. Never do it again. Done. See? But a lot of us can tolerate the drugs, and that's really not good. Okay? So let's get into this. MASH. I want you to understand that. You should check your liver. You get it very good. You can come on the app and I can teach you all this stuff. Check your liver, check your kidney, check your heart, blood pressure, check your organs. These are the organs, guys. This is the money right here. Okay, medications. So these are medications, of course, that are going to be utilized in this world of testosteronology to limit the conversion and aromatization of testosterone into estrogen. So aromatase inhibitors, anastrozole, letrozole, there's some other ones. Look, if you do it, you use them sparingly. You do it only after you understand all these systems and what's happening to you. And is estrogen really to blame? And you've microdosed testosterone. You've picked your ester. You've got your weight down. You don't drink, or you've dealt with that. You could use some of these supplements. You see what I did, guys? I'm cutting it down for you. And then in the end, If you're on the lowest dose of testosterone, doc, I've lost my weight as best I can, or I'm trying to lose weight. My mental health is important. I understand my mood disorders or their lack of, the exacerbation of the anxiety with my life, my wife, and all my kids, and all the work and the stress. And I understand this, doctor. And then now, I think I give patients small doses of anastrozole, 0.25, or I give one little baby, they're not for babies, they're tiny, they're 1 milligram anastrozole. And you can get it at any pharmacy, because women still use it for breast cancer. And then you can cut them in half quite easily, that's 0.5. And sometimes that's great to use on day 2 or day 3 after the injection, to just whack that estrogen. But you don't want to crush your estrogen. This is my whole take-home message of this. But sometimes I like guys to even break that half into a quarter and use sparing baby doses and go by feel. I let my patients do it. And typically you take breaks. You don't live on it. The anti-aging places just give you the 200. They give you all the anastrozole, whatever other drug you want based on your money, based on the Chinese menu. I'll take the wonton. I'll take an egg roll. I'll take the egg foo young. Give me some chicken chow mein. It's just wrong, guys. You have to do this yourself. That's where Testosteronology app, and where I am here to help, and all my testos. So you can use this stuff very sparingly. And what's next? The SERM, tamoxifen and raloxifene, that's only for sensational gynecomastia for a short run, maybe a week or two, maybe once or twice a year. Voila. That's how it's used. But I don't like them, because if you look at the side effect profile, if I've seen maybe half a dozen blood clots that may have been related to these drugs, because I have so many thousands of patients over 20 years, they're so rare. But if a doctor sees it, you just don't forget it. And it's just like, do I want to give that to someone else? And I never have had a patient had a blood clot from one of these medications, but they've come to me and said, Doc, I'm here with you now because I was at this clinic, I had this, and the clinic just gives them the drugs they wanted. And then I had a DVT, and the doctors, they don't know if it's from that, but the timing, the historical timing, the temporal period where they gave it and then he had a DVT. I mean, if you just Google the side effect profile of tamoxifen and raloxifene that are used in this world of this steroid world and this PED world, which again, we're using drugs off the tray. They're repurposed, guys. They're not FDA cleared for men on testosterone and steroids. They're for breast cancer, but for 99% of breast cancer is women. 1% of breast cancer is men. If you ever have a gyno and you have a mass, you better be careful to make sure, with the grace of God, it's not one out of thousands or 10,000 that it's a man that you have breast cancer. Again, 1% of breast cancer are men, but it's not 1% of men have breast cancer. But if you have breast cancer and you're missing it, that's going to be a tragedy. I've seen a few men with breast cancer. I was a primary care doctor. You'll never forget it. Man, the guy's whole pec they removed the whole pec. It was flat. They removed his axilla like a woman. Oh my Lord. And this guy wasn't on steroids. He just had genetic, bad genes, just bad luck. I am not kidding. You don't want to miss that mass. When I have a mass in my patients, I say, look, I need a surgeon to evaluate that, primary care doctor. I have to work together. That's what I'm doing for you guys. So again, SERMs, I would be careful, limit, and then other drugs that are used. The other SERMs that are fertility SERMs, which are clomiphene and enclomiphene, that we're seeing used more and more with testosterone right now, which again, I'm not against it, but you're getting full of fluid and your estrogen's going up. If you take testosterone plus HCG, yeah, good for the testicles for a time, not to mention there's downregulation. Guys, if you're new to this, Thinking caps are on, and it's going to be a long ball game. And it's never going to, nothing in life is ever completely sustainable. It's ever changing. There's tolerance. There's downregulation. There's upregulation. There's dynamic changes. Your body's always changing. Using HCG with testosterone is estrogenic. Maybe you want to lower your testosterone dose to make up for the HCG that you give. I do it all the time, guys. And that's where you are looking at your labs. So estrogenic doses, right? So the HCG, the SERMs, clomiphene and clomiphene, these are estrogenic. They're not aromatase inhibitors, but they're known as anti-estrogens. It's very simple, guys. This is really not complex at all, but you have to understand the nomenclature here and the lexicon. I want you guys to understand that. I want you to fact check all this, but just get it from good sources, the information. You want to limit these meds right here, and you want to limit these anti-estrogens. Okay, next, when should you go for labs? You should go for labs. We typically go for labs at the nadir, and that's just nadir dosing historically, because doctors are giving cypionate 200 every 2 weeks or a month, and they don't want to see it right after the injection. I'm not against the doctors. It's just a historical American strategy to when you're monitoring men on cypionate, typically, or enanthate, even Sustanon 250, and you're giving the injection every week, 2 weeks, or even every month. The doctor would look at the nadir because they want to see the lowest, because the doctor doesn't want to see that high number. So if you need to know empirically, guys, first of all, you need to be at steady state. Don't start testosterone and go to the lab in 2 weeks. Give it 6 weeks to 2 months. Then you're going to be at what's called pharmacologic steady state, right? It's 5 half-lives of the drug. The drug half-life is about 7 to 8 days here, guys. Enanthate and cypionate are very similar. So is Sustanon 250, but Sustanon's got the 4 esters, so it's more dynamic. There's no question. There's no rocket science. So when you go to the lab, are you at nadir? And always look at the same nadir, apples to apples. If you go to the lab too early, you just have to tell the doctor so we can predict, like, you were on the up, you were at the peak, you were on the down. You have to work one-on-one, and you have to understand it yourself. And don't live by the numbers. The numbers are going to be dynamic. Don't live by those numbers. Understand the numbers. Integrate that number into your regimen. And how do you feel? And what are your ABCDs for your heart? See, guys, I'm helping you. Your prostate, your heart, your ejection fraction of your heart, your blood pressure, your calcium score, your heart, A, B, C, D. I'm telling you, this is the only way to do it. And if you're not lazy, you're going to do it on the app with me, and I guarantee you're going to love it. Now, don't use total estrogen. Do not use total estrogen. If you're in other countries and you don't have ultra-sensitive estradiol, liquid chromatography, mass spectroscopy, there's even different ones on that. You can't live and die by it, but you want to look at ultra-sensitive estradiol, because total estrogen can be contaminated, and they can be fictitious. They're going to be falsely elevated. I've seen horror stories where guys are taking more and more anti-estrogens, toxic, 1 milligram a day, even more of anastrozole, and their estrogen still super elevated because it wasn't estrogen. It was something else in the system that was contaminating it, stimulating it. The machine is being falsely stimulated. It's because it's contaminated, and it's something else that's making it look like a spike on that assay, and it's wrong. I've made this mistake myself, again, 20 years ago, even about 10 years ago, 15 years ago. I finally realized when I called the medical directors I think it was Quest, and I got into a fight with a guy because he was like so pissed off, like, why was I asking these questions versus total versus ultra sensitive, and what are these, why is the total sometimes wrong, and it's all over the board. And he was he was really asking me, like, I'm going to call the state on you're a steroid doctor. And I was like, no, I'm not, man. This is a long time ago, before testosterone was so big, right? Like it is now, with all the clinics and people just understanding this knowledge and education. And I was like, no. I'm helping these guys. Well, what are you doing with estrogen? And I was like, well, we look at it, and I want to know my clear data. What is the best methodology to test estrogen in the lab? He's a PhD in the lab. Again, this is not a Yahoo. And in the end, I talked to him a couple times. I'm sure he looked me up and was like, oh shit, this guy's like the anabolic doc and he should be in jail and all this. We're done with that. Like, I'm past those years, right? Here we are. So, and thank you guys so much for all your support. I mean, I can't thank you enough, because we're going into like 10 years now, right, with all the media. So thank you. So, okay, we're done. So that's the labs. What else does it say here? Peak and trough, understand it. Last piece here, guys. If you made it to the end here, anabolic steroid synergy. It is true with DHT-derived drugs, Masteron, and I think more Primobolan. They're not like aromatase inhibitors, but they definitely work similar to this is, again, you guys, if you think you know this, give me some information feedback on this. So Masteron and DHT-derived drugs are dry drugs. When they're used with testosterone, this is the now and the future of utilizing synergy of appropriate medications that are in your country, that hopefully are not illegal, because we don't have them here, so I can't recommend them here. But this is a big world. This is educational. This is not medical information or advice in any regard at all. But this is the science. It's not able to interact with aromatase. I've read that, and I'm telling you. But it may have anti-estrogenic effects by binding with like a SERM, like on the breast tissue. Okay, because it's used. Some of these drugs were used for metastatic breast cancer. Guys, fact check it. Fact check me on that. That's why we need to start researching these drugs once again. Since the 1990s, when they were politicized and shut down, we've just sadly sat with no research or underground. Now they're coming above ground, and I'm a leader to do it. Systemic estrogen may actually go down too, because it competes for the receptors and co-action. There's co-effects that modulate the free testosterone balance. Listen to this. When you use some of these DHT-derived drugs, I think Primobolan more than Masteron, guys, and there's also Proviron. Now listen to this. It can allow you, this is the secret take-home and the goodness of this, that you could use less testosterone, having a stimulated effect to feel good, DHT, but again, it's going to affect your hair, it could affect your prostate, could affect acne and your brain, guys. But in the end, can you use less testosterone, so therefore you get less inherent aromatization? That's how you're controlling your estrogen, because you're using less, because you're using synergistic androgen from a DHT class. Guys, I'm going to wrap it up. Thank you so much for staying with me on this brain trust for you guys. I love it. I hope this is a big hit for you guys. Please show everyone this and leave a lot of really cool comments. Thank you so much. I'll see you on the Ask the Doc meetings over in Testosteronology.